So good morning to everyone who has joined. This is one of the webinars that Global Arch is organizing for its members. I think we have these about every month to discuss different topics we have some webinars, actually some meetings where we can have free-flowing conversations, and sometimes we have presentations. And so today is one of those presentation days. And we have Dr. Dominic Vervoort, who is going to speak today about how to find data when we do advocacy, and specifically how to use the data from the Global Burden of Disease study at the Institute for Health Metrics and Evaluation. And so Dom is finishing his master's. He's actually finished medical school, and he's finishing his master's in public health and also MBA at the Johns Hopkins University in Baltimore. And he is about to start soon, I believe, his residency. And he's also a board member of Global Arch and a great advocate for cardiac surgery and cardiac services globally. So Dom, I'll pass it on to you, and you can start your slides. Whether it's slides or you're sharing your screen, we'll see how that will work. Go ahead.
Can you see this? Can you see my slides? Okay, perfect. Great. So perfect. So thank you so much, Bistra, for the kind introduction. So I'll be giving a kind of a general overview of the global burden of disease study, and especially how it pertains to cardiovascular diseases. And then in particular, kind of giving you a couple of tips and tricks of how to use that data for leveraging that for more effective advocacy, especially then with a focus on RHD and CHD. I'll start off with a big advocacy piece or a big advocacy number from the perspective of RHD and CHD, and that is that unfortunately 6 billion people, or 93% of the world's population, still lacks access to cardiac surgical care when needed. And so what I want to do through this presentation is giving you a bit of an overview of cardiovascular diseases in general, in terms of the background from the disease burden. Secondly, discussing the Institute for Health Metrics and Evaluation and how it pertains to the global burden of disease data. And then lastly, how to use that data and use the Ischemic global burden of disease study for more effective CHD and RHD advocacy. So to start off from a cardiovascular disease perspective, I think we're all very much aware that cardiovascular diseases are a leading cause, and in fact, the leading cause of morbidity and mortality worldwide in both high and low and middle income countries alike. And every year, 18 million people die due to cardiovascular diseases, of which over 80% or over 15 million people of those take place in low and middle income countries each year. So when we look at the global burden of disease study, and when we look at some of the key papers that have come out in recent years that have told us about these big numbers with regards to cardiovascular diseases, but also specifically for rheumatic heart disease, for congenital heart defects, and so forth, these are three key papers that have stemmed from that. And dozens and dozens and dozens of other studies have also come out of this global burden of disease study, but these are the ones that I really want you to focus on for the remainder of this presentation, just to kind of have as a reference, but also at the same time for potential future reference in any of your work that you'll be doing. On the far left is a general overview that has described the global, regional, and national burden of cardiovascular diseases, which was published in 2017 in the Journal of American College of Cardiology. The central one was a critical one that showed that over 30 million people worldwide live with rheumatic heart disease. It was published in the New England Journal of Medicine in 2017. And in the far right one is a rather recent paper that was published, I believe it was in early 2020, with regards to the global burden of congenital heart disease, which was the first of its kind at that level, or from that size, to look into the global burden of congenital heart defects all across the globe. And so these are some figures that have stemmed from those papers, and this kind of already gives you a first snapshot of why it is so important to leverage data for more effective advocacy, simply because beyond mere numbers or beyond raw data, for individuals, whether we're speaking to the public, whether we're speaking to patient family organizations, to policymakers, funders, and so forth, it is much more easier to grasp visual data or visual data depictions as opposed to raw numbers. And this are two snapshots of those, with to the left from rheumatic heart disease showcasing where the most disability adjusted life years are lost due to rheumatic heart disease. And I'll discuss in a future slide what all of these terms actually mean in detail. But basically, in brief, it shows that the darker areas, those that are green, that are orange, that are red, are the areas that are most heavily hit and have a greater burden of a certain condition. And in this case, on the left, with regards to rheumatic heart disease, on the right, with regards to deaths per 100,000 infants, also darker is worse, is a higher number per 100,000 population, or in this case, infants. And also we're seeing a very similar regional distribution in sub-Saharan Africa, in Southeast Asia and South Asia, the Middle East, and Latin America. So as I already briefly alluded to, rheumatic heart disease is one of the leading cardiovascular diseases. It's a mostly surgical disease. It's over 30 million people currently living with rheumatic heart disease worldwide, and that burden is only growing. Rheumatic heart disease is mostly eradicated in high-income countries, except for certain populations, such as indigenous population, immigrant populations, and so forth. But it's still majorly affecting low and middle-income countries worldwide. And it's especially there where the majority does not have access to surgical care. And as a result, there is a great burden of rheumatic heart disease with regards to severe disease complications and surgical and eventual fatal complications. And secondly, and that's probably the disease that people mostly think about when we speak about cardiovascular diseases, is ischemic heart disease or coronary artery disease as a very specific subset. And that is obviously the leading killer worldwide, especially in high-income countries. But due to the transition, the epidemiological transition from low and middle-income countries from infectious diseases towards non-communicable diseases, being mostly chronic diseases, the burden of ischemic heart disease is also growing in low and middle-income countries, and especially in younger populations, meaning affecting them at younger age, having a bigger effect on their working life, having a bigger effect on their families, having a bigger effect on socioeconomic potential of individuals, families, and countries as a whole. And so it's definitely important also to look from that perspective. And then lastly is congenital heart disease, or CHD. And CHD is the most common major congenital anomaly affecting 1 in 100 babies, yet over 90% remains untreated, and about 200,000 child deaths could have been prevented each year should comprehensive care be available. And so these, especially rheumatic and congenital heart disease, are the diseases that I obviously want to focus on in the coming slides, given obviously the focus of Global ARCH and your individual work, but also simply because of the vast burden of preventable morbidity and mortality stemming from those two conditions. And so in the coming slides, I really want to bring you or take you through a journey from the Institute of Health Metrics and Evaluation to really showcase how you can get that data and how you can depict your own graphs, your own figures, et cetera, and use that for more effective advocacy moving forward. So the Institute for Health Metrics and Evaluation, or the IHME abbreviated, is an institute based in Seattle at the University of Washington, and is basically the largest such body that convenes data with regards to the global burden of disease all across the globe for a long list of conditions, which include cardiovascular diseases, but also subsets of those diseases, such as, for example, rheumatic heart disease, congenital heart defects, and so forth and so forth. And they do that for all age groups. They do that for all sorts of measures, which we'll discuss in just a second. They do that for different risk factors for conditions, for different causes of diseases, but also for different years. And so they tried to do that for different year and for every single country or territory worldwide, as well as regional groupings, such as, for example, looking at low and middle income countries, looking at the World Bank categories of regions, such as, for example, the Americas or the European Union, or North Africa and the Middle East and so forth. And so you can use it really to be very specific in terms of the data that you pull out of this. As you see on the bottom, you'll see a couple of rows with general data, and it looks like a spreadsheet like on Excel or any other spreadsheet. And this is not necessarily data that you have to worry about too much if you feel that it's too abstract to grasp the data. But if you do feel jumping into the raw data, then this is a good opportunity to do so, simply because it gives you an opportunity to look at very specific data in a numerical form, especially if you want to use key numbers or key figures in terms of your advocacy. Now, when you click on causes, you'll see a drop-down list, and you'll see a drop-down list with each of these headings. But when you click on causes specifically, you'll see a long list that shows, for example, cardiovascular diseases, or you can click which of those that you want to look at. Do you want to look at individual cardiovascular diseases or cardiovascular diseases as a group? And you can do either way, or you can do both to kind of see how that compares. And an example of that would be rheumatic heart disease. There's also congenital heart anomalies, which is listed under congenital heart defects, congenital defects, but not under cardiovascular diseases. But you'll notice that for cardiovascular diseases, there is a big list. For congenital defects, there's a big list for infectious disease, and so forth and so forth. And so you can really play around and see how each of these conditions compared to other conditions in different age groups, different countries, and so forth and so forth. Now, something important that I do quickly want to address is terminology, not because it's very captivating to go through, but because it's very important for you to be aware of when advocating for the global burden of disease, especially using some of these data or some of these numbers, simply because it might be that not every audience might be fully aware of what this terminology entails. And this is also to make sure that you're able to convey that message to your audience as well in the best possible manner. So when you click on measure, simply similar to what we have done for cause, you see a drop-down list as well. And you'll notice a couple of these are very self-explanatory. Like, for example, deaths are simply deaths, the number of deaths there are due to a specific condition. Maternal mortality is the number of deaths due to a maternal complication. And that is something that you would only have to click on if you want to look at maternal health issues, such as, for example, obstructed labor, postpartum hemorrhage, and so forth. And so this is also not something that's necessarily relevant for this, but the other terms I quickly want to delve into just to describe them. Prevalence, to start with, prevalence, which is the one that you see here on as fifth, is the number of cases there are per population. So when we speak about prevalence and we say, for example, there is a prevalence of 100 per 100,000 population, it means that for this condition, there are 100 cases per 100,000 population. Incidence, in turn, showcases how many new cases there are for a certain condition per population per time unit. And in the case of this database, it would be per year. So when you click on incidence, you can look at how many children, for example, are born every year with congenital heart defects per population. And you can look, for example, okay, does this differ in my country versus another country? Does it differ by region and so forth? You can do the same for rheumatic heart disease and see which countries are most affected in terms of new cases of rheumatic heart disease. Whereas prevalence is a burden that kind of adds up with incidence every year, unless a condition is treated and completely cured. And so prevalence is basically that sum of new cases if there's no cure for that condition and if people don't die, whereas incidence is really the new addition of cases every year. Now, the other three that you see above, the abbreviations DALYs, YLDs, and YLLs, are slightly harder to grasp which is why I'm adding this figure to illustrate, but they're very important, especially from a DALY's perspective, because a lot of policymakers, a lot of funders use that as a measure to see, okay, really how big is the burden, not just how many people die, but also how many people live with a condition that's affecting them in terms of their daily life. And so a lot of cost effectiveness analyses, a lot of policy decisions, a lot of funding decisions, et cetera, use metrics such as DALI simply to see, okay, can we not just ensure that people don't die as early, but can we also ensure that if people don't die, they're still able to live a healthy life? And so the abbreviations are written in full above, and you see DALYs would be a disability adjusted life year. And that basically is, as I mentioned, a measure of the overall burden that captures both how early one dies, so how many years of life one has lost due to dying early due to a condition. And you see, if you look at the years of life lost, or YLL, at the right bottom, you can basically see, okay, that is the difference between the normal life expectancy, or the expected life years, and the time at which one has died, unfortunately, due to a condition. And the difference of that are basically the years that one did not get to live because of that condition. Now, similarly, YLD would be years lived with disability, and that is the years that one is still alive, but one has a condition and is thus unable to live a healthy life, whether that is going to school, whether that is going to work, whether that is living a life where one can do normal activities of daily living and so forth. And those would be the YLDs, and that basically shows, okay, how much is one affected with a condition when you're still alive. And combining those two would be a DALY. And that basically shows all of that together, the burden after and before an individual, or in this case, a population, passes due to a condition, is that burden that we really want to measure. For the coming slides and for your own personal reference and personal information and your advocacy work, deaths and DALYs will be most important to reflect on. YLDs and YLLs are less important, mostly because people group it as a measure in DALYs, which is obviously showing a bigger picture. And prevalence of incidents can be helpful to showcase how many people live with it or get it every year. And so you can kind of play around with those different measures to see which one best fits in terms of the message that you want to convey. So one last raw data slide is that we basically looked at it here for congenital and rheumatic heart disease. As I've shown you earlier, you can do that for a variety of conditions. And here I've tried to look at it for congenital and rheumatic heart disease for age groups under 5 and age groups 15 to 49. And you can basically see where, if you look at this table on the left, you see which measure we're looking at, which is deaths. We're looking at the location, which is global, so anywhere worldwide. It's both sexes, so it's looking at both male and female jointly as one group, although you can also disaggregate if you want to. You have the age groups and the causes, you have the metrics. So here we're looking at the total number, the absolute number. So how many people, for example, in the first row are dying due to congenital heart defects under 5 years old in 2019. And that would be globally in 2019, 174,000 children dying from congenital heart defects. Whereas the second one would be the rate, and that is the number per 100,000 population. So in this case, that would mean if we take all children that are 5 years or younger in the world, and we take this deaths per, which is a total number, when we look at that per 100,000 children under 5 years old, that would be about 26. And this is a good way to kind of compare between different conditions. Okay, really, how big is that burden in the age group? When you look at the rheumatic heart disease burden at the same rate, also for deaths on the sixth row, I should have marked it with colors. You see it's 0.25, and you see that in children under 5, rheumatic heart disease is not yet a big cause of mortality, but it is mostly because rheumatic heart disease tends to occur a bit later. And as you go up in age groups, such as, for example, in 15 to 49 years old, you see that the burden is already quite higher, whereas congenital heart defects is slightly lower. And that is simply because globally, unfortunately, the majority ends up passing away before the age of 5. Now, that is all kind of hard to grasp, especially if you want to use it for advocacy purposes. And that's why there are a couple of tools that you can use to really visualize some of this. The Institute for Health Metrics and Evaluation, again, has a couple of tools for you to do so. And one great tool is called the Viz Hub, or Visualization Hub, but then written in short. And what you can see here is basically a snapshot of that. You have the website link at the top, but I'll show them on a separate link in just a second. So if you want to take a screenshot, you can do so then. But it kind of allows you to compare different disease groups, different countries, years, different age groups, male versus female, and so forth in a variety of manners. You could do it as one square, as you can see here, where you see what the proportions are. You can do it in a variety of other means, such as, for example, looking at a world map and saying, okay, I'm interested in looking what the burden of congenital heart anomalies is for both genders or for both sexes under 5 years old in 2019, looking at deaths per 100,000 population. So in this case, we're looking at that specifically, and we see that, again, the burden is largest in low and middle income countries, in South America, in Sub-Saharan Africa, in Asia, mostly in Southeast Asia and in South Asia. And this allows you to look at it visually across the map, but also compare with different groups or different countries. This is for rheumatic heart disease, and you see a similar distribution. But what is interesting is that for each of these countries and each of these groups, you can click on the country or you can click on a region and see how big is the burden within that country or within that region for the group that we have selected. Here in this case, we would look at Papua New Guinea because it's one of the most affected countries, unfortunately, because of rheumatic heart disease worldwide. But you can do it for any country that is depicted here, or you can play around with the dashboard on the left, where you can select in terms of detail, really how detailed you want to be. Now, the IHME allows for some countries, like for example, the US, China, Mexico, Brazil, etc., for you to dive into specific states and provinces or regions. And so if you are, for example, from Brazil, or if you are, for example, from China, and you want to look at what is it for my specific province or state, then you can increase the level of detail to the left to, for example, 2, 3, or 4, and then it showcases for your specific state or province what is that specific burden. And so as you can see, you can kind of play around with a lot of these metrics and see which is the message that you really want to convey. Now, if you look at the left, at the far left, you see a couple of black boxes, you see a couple of lines, etc. This shows which ways of visualization you can use. So the ones I've shown to you thus far, just to kind of take a step back, sorry, is a visual depiction on a map, is a visual depiction as a block to see the proportion. But you can also showcase it as a rank of the burden within a certain age group, within a certain set of categories, and how that changed over time. And that would be the third block on the far left. And so here we can kind of compare, for example, and that's what I've tried to do here to showcase how you can kind of play around with it. We can compare how high middle income countries from a SDI perspective, which is just social development index, socioeconomic development index, how that compares for this country group versus the world as a whole at the bottom. And looking at that to see under 5 mortality, how has that changed over time? So you can see at the bottom that it's mostly infectious diseases when we look at the world as a whole. But when you look at specific regions, like for example, high middle SDIs or high middle income countries, we see that congenital heart defects, for example, was very high already on spot 4 in 1990, but rose to number 2 in 2019, being currently the second highest cause of morbidity and mortality. So the second biggest disease burden in children under 5 years old in high middle SDI countries in 2019. And so that's kind of a mouthful, to describe what you're seeing here, but as you can see, pictures themselves show much more than if I were to explain it in words or if we were to describe it in words. And so that's why it's very handy to have tools like this to play around and really leverage that data. A couple of more examples are, again, that comparison. If we would use a square, because we're comparing two groups here, it changed to a rectangle, but it's still the same in terms of the proportions that it's showcasing. And so you can compare different groups and really see, okay, visually, how does that change? And we've done the same here, where just now you had the ranking in terms of the burden by year and how that ranks as in one, first, second, third, and so forth. But this is a visual depiction in terms of the proportion. And here you see as well, congenital birth defects are a leading cause of morbidity and mortality in high middle income countries, as well as across the globe. But globally, it would be a smaller proportional share simply because of the larger proportional share of neonatal conditions and remaining infectious disease burdens. This is another way of visualizing. It's also one of the options that you have in the boxes or in that dashboard, and that you can click on. And here you can, for example, compare by region, by country, again, similar as you could do for any other visualization tool. But what I've looked at here is really looking at those different regions: low SDI, low middle SDI, middle SDI, high middle SDI, high SDI, to see how are different country groups, depending on their socioeconomic development index, comparing against each other, and how are they comparing to the global average, which is on the far right. And you can see, for example, congenital heart anomalies, which you see right below the box that is showcasing the burden of congenital heart anomalies. You can see that it's number 11 or ranked 11th in low SDIs. You can see that it's 8th in low middle, 5th in middle, up to 2nd, as we shown earlier, in high middle SDIs, and 3rd in high SDI countries. So you see that it's mostly countries who have a higher socio-economic development that have a larger proportional share due to having addressed a big burden of their infectious disease burden. But in all of these countries, as the infectious disease burden gets addressed, it becomes more apparent that underlying that congenital heart disease burden, and in case of rheumatic heart disease, in many low and middle income countries, that burden is very vast as well. So these are some key websites that you may want to refer to. The first one is showcasing you the general raw data in that database, which is the results tool. The VizHub allows you to visually compare those data, and the bottom data is just general information for the IHME that you can refer to. And then lastly, before I delve into any questions that you may have, would be the advocacy, the use for this data in terms of advocacy for CHD and RHD. So unfortunately, I'm not going to delve too deeply into this, but unfortunately, political commitment for CHD, RHD, and cardiovascular disease in general, both at the level of WHO, the United Nations, as well as in terms of individual ministries of health and governments, is still limited. And so it is very critical for us to address the issues pertaining to cardiovascular care across the globe, especially as it pertains to some of the myths that have prevailed that tell us that supposedly cardiovascular diseases have no role in global health, that cardiovascular diseases cannot be addressed in global health, and so forth. But luckily, all of these things are actually myths, and we can, through effective advocacy, can address this and can ensure that people understand really what is the reality, what is the current burden, and what should policymakers, funders, patient and family organizations, and so forth know about what is a true burden and what do we need to address to make sure that people with CHD and RHD are able to live a longer life. And so it's important to use that data for especially those purposes, really to spread awareness, for us to ensure that we have a seat at the table as a community and ensure that policymakers are listening to us, that decision makers, state leaders, funders, and so forth are actually ensuring or having recognition or recognizing the issue of congenital and rheumatic heart disease worldwide. That we're telling our peers, our colleagues, our friends, our families family members about this issue, and that they can tell others, and that eventually catalyzes a snowball effect, for example, by passing on flyers that you've created showing some of this data. But also from a research perspective, that we better understand what does this burden mean, how does this affect our local communities, our fellow, um, our peers, our colleagues, our family members, and so forth. And really, what are the issues that we have to address to make sure that this burden globally is addressed as well. And so various NGOs have been very effective in using that data for advocacy purposes, and Children's Heartling is one of the leading NGOs that has been doing so for cardiovascular diseases, and then specifically from a CHD perspective. And I definitely recommend you to have a look at these 4 PDFs, which kind of merge raw data, visualization of that data, and a text for further information and experiences by Children's Heartling and their partner organizations in terms of addressing the global burden of congenital heart defects. And similar ways could be done by your organization, and similar ways have been leveraged by other NGOs as well. And we obviously have Bistra on the call as well, who can share some of our experiences with that later. One specific issue that I briefly alluded to earlier, which is the fact that as countries become more developed or address their underlying disease burden, such as, for example, infectious diseases, neonatal conditions, and so forth, it becomes more apparent that cardiovascular diseases such as congenital heart defects, rheumatic heart disease, and so forth are very prevalent and are actually pressing on countries' health systems, are causing for very premature, very early death and morbidity in countries worldwide. And as these burdens are addressed, it becomes more apparent that this is the case. And so tools like this really allow us to say, okay, well, we don't have to wait until the infectious disease burden is addressed for us to advocate for example, children born with congenital heart disease, children and young adults living with rheumatic heart disease, and so forth, because that data is already there. We just have to showcase it in the right way to make sure that people are aware of it, and they're not just looking at the number 1 or number 2 in their country, because obviously that gives a very fragmented and very skewed figure. Similarly, you can use the data to spread awareness, not just in terms of creating PDFs or flyers or put it on your website, but also to advocate on social media and online, et cetera, in any kind of way, whether that's on Twitter, whether it's on Facebook or Instagram, newsletters, your website, and so forth. And these are just a couple of examples. You see on the left top is a podcast that was given about the paper that I briefly described earlier about the global burden of congenital heart disease that came out last year in 2020. On the bottom, you see a picture of a conference where Bistra actually presented that slide or that figure that I showed previously at one of the pediatric and congenital heart surgery conferences. And on the right, you see how data was initially used by the IHME and then retweeted by Bistra to showcase that the global burden of cardiovascular diseases is still very high, but we can really address that through a variety of means. And you could, similarly as we have done for specific disease burdens, you can also do so for risk factors for conditions, as the IHME has done, and here nicely depicts how that has changed, whether that has changed over time, and really what are the biggest factors that we have to address. And you can also lastly use that for media advocacy, whether you're talking to local media, publishing an op-ed, presenting this as a white paper, etc., to showcase what the burden is and speak to the public, speak to local media, speak to local funders or policymakers, or speak to national outlets and tell them more about what is the burden, what needs to be done, and what is happening that people are unaware of. And then lastly, from a research perspective, even though we have a lot of this data, it doesn't mean that we know everything about that data. As I mentioned, a lot of people are unaware and needed to be visualized, but at the same time, a lot of this data tells underlying stories that we are not necessarily aware of. So this is, for example, a research study that we did 2 years ago and published last year that tries to look at, okay, we know now how many children, children under 15 are unfortunately dying due to congenital heart defects. We know how many of them live with congenital heart defects. We know what the burden of congenital heart disease is. But unfortunately, we do not know how many of those could have been prevented, how many children's lives could be saved, how many children could be prevented from carrying that burden and living a healthy and normal life. And we try to look at the data and see, okay, what are some of the gaps between countries? And with that, found that almost 200,000 children could have been saved every year if comprehensive care for cardiovascular diseases, surgically, pharmacologically, in terms of secondary prevention, etc. If that all were to be in place, approximately 200,000 children could be saved each year, children's lives. And you can do a similar way of looking at different other disease burdens or disease groups. And you can also delve into it in terms of your own country or region to look a bit further. And as you can see on the right, obviously, you see a very similar regional depiction, but it also again showcases really what the difference is between a very dry chunk of text on the left, which people might gloss over, and the power of a figure to the right for really describing that information in one single figure. And so lastly, I want to close and obviously recognize the fact that this is a Global ARCH webinar, and that I do encourage you to have a look at the Global ARCH website and social media accounts, but also to take that lesson from a snowball effect and tell your friends, peers, family members, colleagues, and so forth about Global ARCH, about the burden of congenital and rheumatic heart disease, and really use those lessons that I hope to have conveyed to you throughout this webinar, as well as using those tools from the IHME to be a more effective advocate for CHD, RHD, or whichever condition you are advocating for. So with that, I want to close. I want to thank you for the opportunity to present, and I'm happy to answer any questions.
Thank you so much, Dom. This was really wonderful and very informative. I hope people find it informative and helpful in their advocacy efforts. We have two questions, and then I'll ask you some. So the first question is from Noemi de Stutz, and she says, new cases also includes newly diagnosed disease that was pre-existent. So she's asking, is that true? The new cases also include newly diagnosed disease, such as late diagnosis of CHD in places where there's no screening and birth. So do we know that, or is it just new cases at birth?
Yeah, so there is, and I guess that also to an extent covers the second question. So I guess I'll cover that at the same time, because it pertains to the accuracy of the data from the IHME. And that's, unfortunately, that's kind of still an issue, because the way that the IHME works and how they compile their data is that they use any kind of means of recognized or validated data that is out there. So they use peer-reviewed publications, they use Ministry of Health reports, they use reports by the WHO, they use reports by any kind of recognized agency within a country that is allocated to studying the burden of disease. So that could be, for example, institutions like, for example, UNICEF. It could be institutions that come from NGOs that fund specific initiatives, such as Bill and Melinda Gates Foundation, such as Gavi, et cetera, et cetera. And so through a variety of those data, all of which to different extents have been validated and peer reviewed, they basically pull that data and try to find an estimate that is most accurate, depending on an age group, depending on a measure, on a disease category, on a country, and so forth. And so for some of these data, they have a very good estimate. They have a very reasonable estimate. It could be, for example, that there was a study that looked at what is the congenital heart defect incidence or prevalence in Mozambique, across Mozambique, doing community-based screening, et cetera, et cetera. And so it could be that that is very specific data that is likely very accurate because of how the study was set up, et cetera. And so that would be very good for that data in the database to say, okay, well, this data is very accurate. At the same time, for certain countries, disease groups, age groups, etc., it might be that there is not as much data available. There is always data available to some extent because of simply the fact that countries have to report WHO reports, etc., etc. But for some of them, they have to make a bit more assumptions and say, for example, okay, in a country of a similar socioeconomic development, similar size, similar population structure, et cetera, we might have to make some assumptions and assume that the data burden or the disease burden is the same or similar, not necessarily the same, but similar as it is in the country that's comparable to this. And so they do have to make some assumptions to generalize some of their data to an extent. And so some of the data is not fully accurate. There are estimates still, but the IHME data is the most kind of reasonable estimate that we have for the disease burden, or really what we have to work with. Now, by all means, if you have data that's available locally because of a community-based screening that you have done, or there's a study or so that addresses that very specifically, then by all means use that, because you know that this is much more specific and arguably a bit more accurate for that given set of conditions, for that given population, disease group, region, and so forth. And with that, you can obviously also use kind of the same principles of visualization. Now, to answer then the first question with regards to the new cases in terms of newly diagnosed disease for CHD, yes, that also includes late diagnosis in some places where there's no screening at birth. So that's unfortunately another caveat, is that for congenital conditions, or for example, for other conditions like rheumatic heart disease, it is really the point of diagnosis that defines what is incidence. And if somebody is, for example, diagnosed at age 16, well, unfortunately, the incidence will then be age 16, because for most conditions, you don't know when it started. Congenital heart defects, obviously, that starts at birth because it's a congenital defect. And so technically it would be an at birth incidence, but because there's diagnosed at the age of 16, it would have to count as the incidence 16 years earlier when that individual was born. And so they can't retrospectively amend epidemiological data. And so that's why it's included within that age group in those instances. And so there's still, especially for CHD, that might be an issue for some regions, but by and large, again, given the assumptions that are made and given kind of the broad data that's available globally, it is a very reasonable estimate.
Yes, and I would just add to that, that it is true. This is all what's called model data based on different estimates, like Dom explained, that it's based on a study somewhere else, or one small study. Kind of they assume that represents the whole country. There is something that's called confidence intervals, and so the confidence intervals show how big your mistake could be in this estimate. So if you say that your number here is 100, you may have a really big confidence interval. So this number could be potentially 300 to 0, or you could have very small confidence interval between 120 and 99 and 120. And so the confidence intervals for the potential for mistake are bigger for congenital heart disease. And I think that's one of the problems that we're trying to highlight with the Invisible Child series, is that there isn't enough data being collected, true data on the incidence and on the prevalence. So how many children are being born and how many children live with congenital heart disease. And I think the same with rheumatic heart disease too for many countries. And however, having said that, most studies show that it's about the same, that it's about 8 children per 100 are born with congenital heart defect. And so it's that's something that everyone kind of assumes, and so a lot of the assumptions are based on that commonality of congenital heart disease. There are some regional differences, but more or less studies have shown that it is the same across the world. So we can still use this data even as just grabbing attention for policymakers and building some materials that can help us in advocating with them, whether it's for more investment, whether it's for more data to really understand what is the true prevalence and incidence. So that would be my addition to this answer. Can you just share a little bit, Adam, how easy it is to go on a website? I mean, it's free, right? And you can just go on the click on the link and go.
Yeah.
Okay.
Yeah. So it's totally free.
Yeah.
Yeah, it's totally free. I'll copy paste the links as well for easier reference in the chat box, just so you can copy it in case you didn't manage to take a screenshot. It's completely free. You can play around with it and see, get a bit familiar with the tool, but at the same time also see what kind of different ways of visualization there are. I kind of showed you a couple, but obviously when you play around, you see, okay, well, this way of visualization might be more interesting to depict the burden of CHD. This might be more interesting for RHD or for whichever disease group you're speaking about. Yeah, it's a great way to kind of pull that data that comes out of the IHME and the Global Burden of Disease study. That is typically kind of presented in a very dry publication, and those publications are very helpful for the academic community, but they're very hard to convey the same message to policymakers, to funders, to the public, and so forth. And so this tool really allows you to use that same data, but visualize it in a way that it's much more easily digestible.
Yeah. And one more thing about this data, again, this is modeled data, so these are estimates. But I have to say that they are widely accepted. You know, publications about using this data are widely accepted as the norm now. In another thing about the Global Burden of Disease study is that every year this data is improved. So every year new sources come and new information comes in. So the modeling improves every year. So I think Dominic showed you the 2019 data. So next year we'll be able to see the 2020 data. The researchers at the Institute for Health Metrics and Evaluation do that review annually. So that's, I think that gives us some confidence that we could use it. It's been actually, it's being used by some departments at the WHO, and a lot of researchers are using it as well. I don't think we have any more questions. Let's see, no more questions. We probably then, if there are any others, let's give it just a second. I think Dominic also showed you several publications that have used the Global Burden of Disease. So that's, I think, a good example. One thing to share is that we at Global Arch will be putting together templates for fact sheets that use this data. And so our members can take these fact sheets and look at the website and find their country and use them for advocacy in their own countries. So we'll be announcing those very soon. All right, if there are no more questions, Dom, thank you so much. This was wonderful. I hope it's useful. The webinar will be recorded so people will be able to listen. Again, if they have questions, and certainly can reach out to us. Find us on the Global Arch website. Both Dom and I are part of the board of directors and the advocacy committee. Thank you again.
Thank you.
Thank you. Have a good day, everyone. Bye-bye.